So tonight we're talking about breathing exercises, and I really like to start with this quote. It's funny, but you never really think much about breathing until it's all you ever think about. I think that that's so true, isn't it? Because when we don't have a problem with our breathing, you just don't notice that it's there. They say that about the cricket wicket keeper. If you don't notice the wicket keeper after a day of test match cricket, it's probably because he did a good job. But if he's dropped a catch or two, you'll notice it. If you have a problem with your breathing, it's noticeable. It has a significant impact on the quality of life, what you're able to do from an exercise point of view, and how you feel. And so it really is in line with our mission from Lung and Sleep, which is to inspire and help as many people as possible to improve their overall health with specialist attention to the management of breathing and sleep problems. So I'm going to start by talking a little bit about what breathlessness is and some of the medical causes for breathlessness. And the fact that you can have breathlessness without problems with the lung and heart. Leah will then talk about how we should breathe and what is normal breathing and what's an abnormal breathing pattern. And then Ali will take us through some exercises. So breathlessness is a little bit difficult to describe because it's different for everyone, so it's subjective. But it's a complex perception influenced by psychological, physiological, and also environmental factors. And it's frequently associated with anxiety, but I think too often anxiety is blamed as the cause for the breathlessness. And I think it's probably more common that the breathlessness causes the anxiety, which may exacerbate the breathlessness, but I think it's often not the case that the anxiety is the primary problem for the breathlessness, but too often just pushed aside to say, oh, it's just anxiety. It's not always related to underlying disease severity. So you can have very severe lung disease, but breathe okay. But sometimes you can have mild lung disease and the breathing can be very badly affected. And people, when they get breathless, they tend to avoid things that make them breathless. So it leads to inactivity. And patients often avoid things. And then the more that they avoid, the more they decondition and lose fitness. And then that can make the breathlessness worse. So it can be a bit of a vicious cycle. And people describe breathlessness differently. Sometimes people just describe this feeling of being frightened, worried. They feel helpless. Sometimes they feel like they're being smothered. Sometimes it sort of feels constricting, where it might be constricting around the upper airway or constricting around the chest. Sometimes people describe the feeling of being suffocated or not being able to get enough air, just can't get enough air in, can't get enough oxygen. And sometimes it's a tightness around the chest. And so these guys don't really describe breathlessness. They're all breathless, but when they get so breathless they can't run any further, they actually describe pain. And so there are a lot of causes for breathlessness. So when we see someone in the clinic that presents with difficulty or problem with their breathing or shortness of breath when they're doing exercise, the first thing that we need to do is to check to see, is there a cardiac cause or some sort of heart disease that could be causing their breathless, or is there a lung disease? Or is there some other condition that could be contributing? And so there are other conditions that are not related to the heart or the lung that could be causing breathlessness. And we need to investigate for these, because if we can identify a cause for the breathlessness, then the treatment becomes quite straightforward because there's a treatment algorithm for the underlying diagnosis. But people say to me, so why am I breathless if you tell me my heart and lungs are normal? And this is quite a common situation where we do the tests of the heart and the tests of the lung, and they come back normal. And often this is disappointing for people because they perceive the fact that there's a problem, we haven't been able to diagnose it. And I think that that's a really important situation where having normal tests to say that your heart and your lungs are normal does not mean that there's not a problem. If someone tells me that they're breathless, they've got a problem with their breathing, there's a problem. And so we need to address that problem. If we can't diagnose an underlying disease that could be contributing to it, then we need to look at the problem, which is the breathlessness. Oops. So I know my lungs aren't great, but is there anything we can do to help my breathing? And this is another common situation. So some people will have underlying lung disease, maybe asthma or COPD or emphysema. And it may be that they're on maximum treatment and their lung function is still poor and they still get breathless and are unable to do what they would like to do because they're limited by their breathing. And this is another situation where we may not be able to improve the function of the lung or the function of the heart, but there's often things we can do to improve the breathing and the exercise tolerance. And can I get oxygen at home? This is another common question where often it is not low oxygen that causes breathlessness. As a matter of fact, most patients with breathlessness, whether they have heart or lung disease as well, usually is not due to low oxygen. Usually it is due to the lung not working very well or the heart not working very well, but it's not the low oxygen. So it's uncommon that oxygen at home is going to help breathlessness. So I just want to touch on two conditions quickly, which often is associated with normal tests. So the lung function is normal, the heart function is normal. And the first one is vocal cord dysfunction. And this is where you can see here the vocal cords normally sit down open like this. And when we breathe in, they open up. And when we breathe out, they close a little bit. But for some people, they close excessively. So they might close right down during breathing in and out. And when that happens, it makes it hard to breathe. It's hard to get the breath past the closed vocal cords. And this might happen because the vocal cords are being irritated, say by postnasal drip, but maybe because they've been exposed to a strong smell like perfume or smoke from outside, or they may be exposed to cold air or exercise. Something can bring on this sudden closure of the vocal cords and people get breathless quickly and can get very breathless, often feel like they're choking, and then it settles down with time. The clues to this is often it's worse breathing in, often brought on by talking, tends to come on quite quickly, but then tends to get better quite quickly, often associated with a change in voice, can be exacerbated by strong smells and things. And these people normally do have normal lung function. And they don't get better with prednisolone. And that's important because often people who have vocal cord dysfunction sound and look exactly the same as someone with asthma. So they get put on the prednisolone. And if you don't get better with prednisolone, then have to start thinking maybe it's not, maybe there's something else going on. The other one that I'm just going to touch on is dysfunctional breathing. And often when people do have the vocal cord dysfunction, it's associated with dysfunctional breathing. And what happens here is instead of breathing from the diaphragm, people tend to breathe from the top of the chest. And you can see that their shoulders come up, chest comes out, because they're sucking air into the top of the chest. Tends to be something that happens when people feel breathless. So maybe that the vocal cords are closing, making it a bit hard to breathe, and then people's response is to pull the air in from the top of the chest. And the thing about that is that it's inefficient. It makes the breathing feel worse. Then that's when the anxiety starts to creep in. And then that drives the whole situation. And often the vocal cords get more narrow. That makes the breathing harder, makes more pulling the air in from the top of the chest, and you get a vicious cycle of breathlessness that what we need to do is settle that down. And the way we do that is with breathing exercises. And so I explain this to a lot of patients in the clinic, diaphragmatic breathing. However, I'm not the absolute expert on this, and we do have the experts here to describe diaphragmatic breathing and what to do in this situation. And so with that, I might pass on to Leah.
Thank you very much, Barton, for your introduction. And for those of you who in the audience who I haven't met, I am Leah Jennings, and up until around February 2020, I would have told you that my main role at the moment was as the practice manager here at Lung and Sleep. But actually, in reality, my clinical passion and training is as a physiotherapist, and in particular in the area of respiratory care. So, you know, Lung and Sleep is a perfect place for me. But to give you a little bit of an idea of what I do, so today, like many of you probably in the audience, I was also the assistant teacher in our house. And wow, I guess the question is, did I have to breathe today? Quite significantly. So who and what is Lung Life Physiotherapy, and what is it all about? It's a really good question. So Ali and I are both physiotherapists. We've got 30 years of combined experience in delivering respiratory care. We have postgraduate specialisations. So I have a master's in physiotherapy, a clinical master's in cardiothoracics, and Ali has a master of philosophy focusing on geriatric research and respiratory. And together we are both certified Radcliffe practitioners. And to many of you out there, that may not mean a lot at the moment, but hopefully by the end of this presentation, it will make a little bit more sense. So what is respiratory physiotherapy? And I guess the question, that is the most common question that we get, because it is a little bit of a niche area of work, I guess, to be in. But The answer is that often patients with chronic lung diseases such as COPD, asthma, bronchiectasis have ongoing symptoms despite optimal medical management. So this may be in the form of increased secretions or cough that won't go away. And last, but certainly not the least, and probably for us at the moment, one of the most common conditions we see is breathlessness. So respiratory physio is a really important treatment for many lung conditions. So we work with airway clearance in COPD and bronchiectasis, and for the not physiotherapists in the room, airway clearance is really just a fancy name for teaching you how to get rid of the excess sputum or phlegm that you have in your chest. We also manage difficult breathing patterns. Irritable cough, those coughs that sometimes post-viral coughs, but coughs that just don't go away, the runaway cough that you just can't stop, and you might get a little bit of irritation through cold air or other irritants, and it gets you into this spasmodic cycle. We do a lot of work with inhaler and nebulizer education also. And most of what we do as respiratory physios is really provide an adjunct therapy to medical management. So, everything as we as professionals talk to you about tonight may really sound innate, something that comes naturally, something that we just do, but in reality, most of us are born with the anatomy and physiology that allow us to breathe. But what happens then can really be impacted by what happens in other areas of our life. So Sanskrit is a historical Indo-Aryan language, and today it's listed as one of the 22 scheduled languages of India. And I think that this proverb really sums it up. So for breath is life, and if you breathe well, you will live long on earth. So the question is, what does breathing well really look like? So here's a little schematic, and I must say it looks like something that the kids may have put together today during home learning, but I promise they didn't. So to start off with, if we have a look at the process, really breathing is really, very simply put, the process of moving air in and out of the body. Generally, good breathing cycling should start with the nose. So we should take a breath in through the nose, and our nasal breathing cycle is really, really important. So our cycle in our nasal breathing happens around every 90 minutes. So in one side of the nasal passage, at any one time, its job is to clean and clear. While on the other side of the nasal passage, we're filtering, humidifying, so warming the air, and then breathing that into the lungs. The air then comes into the pharynx and the larynx. So Barton spoke about the role of the vocal cords, and the vocal cords obviously produce speech. And then it comes down into the trachea. Now the trachea is this bony, this hard cartilage that you can feel here. So your trachea is held open, it's quite rigid, it's held open with cartilage. And then the air comes into your bronchi and your bronchioles, so the smaller branch-like parts of the lungs. So normal breathing, essentially, the research tells us that a normal breathing rate is around 10 to 14 breaths per minute. And naturally, when we take a breath in, the diaphragm, which sits right at the bottom down here, does 90 to 95% of the work of breathing at rest. So it's a powerful muscle, and probably nearly outside of the heart, one of the most important muscles in our body. So when we are breathing at rest should really be a quiet activity. We inhale actively, and when I say actively, I mean that diaphragm actively contracts to bring air, open up the lungs and bring the air in. And when we exhale, it's what we call a passive exercise. So as we inhale, the diaphragm moves down and opens up and the air comes in, and then the elastic recoil of the body, the chest wall and the diaphragm bounces back to let the air breathe out. So it's a very passive exercise. So breathing, though, is not uniquely impacted just by the anatomy of our body. So it's really, really important to understand the linkages. So our brain is really the central messenger for the body, and to effectively coordinate the cycle of breathing, we really have to rely on the brain to relay the neurological signals and the biochemicals to make the system work. So it's a really integrated system for breathing. The problem is that when one or more of those systems is out of balance, breathing actually can't occur in a normal way. And that's what we term a breathing pattern disorder. So when you have those linkages happening, you can have an area of issue around mechanics or physiology or the psychological aspects of breathing. And when they don't work together, then you really end up with a breathing pattern disorder. And like Barton said, really just because medication doesn't fix it, it doesn't mean that it's not a treatable condition. And it's really important that we recognise that they are really important conditions. So something we often hear about is other breathing pattern retraining programs. So it's not a new phenomenon. There's lots of things around. So I'm not sure whether anyone has maybe heard of Buteyko. So Buteyko, or Konstantin Buteyko, was a Ukrainian doctor, and he created the Buteyko breathing pattern technique back in the 50s, I think it was actually. So this is really a therapeutic breathing method used by using breath control exercises to control the speed and volume of your breath. And it really...
Leah, just before you go on, sorry to interrupt. Who can name the person in the picture? Put it into the chat if you know who the person in the picture is. You can continue to tell us about Buteyko while people have.
So Buteyko helps to learn you basically to breathe more slowly and calmly and effectively. Does anyone know who that is in the picture?
Yeah, we've got some good responses. Wim Hof. Yep.
Wim Hof.
About five people know that it's Wim Hof.
Yep, beautiful. It's not Barton. You're correct. looks like Barton maybe after a long down though. So you're exactly right. So Wim Hof was a Dutch extreme athlete that got the name Iceman after breaking a number of records related to cold exposure. So he has developed a method of breathing using the combination of cold therapy and breath control to regulate breathing. And so as part of his program, you often do breathing exercises in a cold shower. There's many others. Soma breath is another one that people may have heard of, and it's a breath control to maintain really extremely low breath rates. And this relates more, I guess, to a meditative practice than necessarily a breathing control program traditionally that we would use. So what does a breathing pattern disorder look like? Patients really report lots of varying symptoms. And just because you have one or two of these doesn't necessarily mean that you have a breathing pattern disorder. But this is, I guess, gives you the range of things to have a think about. So a lot of people are mouth breathers, will have a hoarse voice, you know, that croaky voice, chronically croaky voice that develops. Frequent yawning or sighing. And when yawning, I'm not talking about the tired yawn, I'm talking about the yawn that you can't quite control. And sighing, I'm not sure whether anyone has, I'm sure people have noticed it, but people will often get to the end of a sentence and then they'll go, and sometimes it's a little bit more silently, but it's very normal to sigh, and we would normally all sigh around 10 times per hour. But people with breathing pattern disorders will often will sigh much more frequently. The other thing that we see with patients with breathing pattern disorders is sometimes headaches, neck or shoulder pain, and low back pain. And you can imagine when Barton demonstrated earlier the breathing pattern that we often see, which is that really upper chest breathing pattern. To actively breathe in this part of your chest, you really need to activate the muscles of your neck and your shoulders, which obviously connect very closely to your head. So people will often get pressure points or very tight muscles, neck pain, shoulder pain, and headaches. There's recently been some really good literature to start to suggest that sometimes gut nausea or reflux contributes or is part of a breathing pattern disorder. I guess in saying that, it's really important to exclude any medical causes for all of these things, or serious medical causes, before we go down the path of treating them as a breathing pattern disorder. Barton spoke about panic attacks. It's a really, really common one. We often see people, again, with a combination of cough, sputum, again, fancy name for phlegm, and throat clearing. I'm not sure whether anyone else has noticed, but sometimes people clear their throat. So they might get to a sentence, go, and without even realising, they start doing it quite frequently. So, wheeze and stridor. So wheeze and stridor, that's really getting back to sometimes related to the vocal cord issues that Barton was talking about. And often with asthma and other conditions, you'll also get a combination of wheeze or stridor. But breathing pattern disorders will give you any number of these symptoms, and they're the things that we would look for. So how do we assess assess to look for a breathing pattern disorder? So the first thing we need to do is really look for a pattern of breathing, and Ali will go over this after I finish to demonstrate. So the first thing we look at is whether you are a nose or a mouth breather, and particularly whether you're an upper chest or a diaphragmatic. That's a belly breather, like a deep breather. A lot of people, like we have been saying, with these kinds of disorders are very much focused on upper chest breathing. It's a really inefficient way of breathing, really hard to control, and makes you very breathless. So nasal patency. So again, it's a fancy word for making sure that your nasal passages are really, really clear. So essentially what we do is look very closely at how well those sinus passages, the nasal flow is connecting, and make sure that they're clear. And it's often a big part of our treatment. Speech. So we talked about speech, the husky voice, the rapid breathing, throat clearing, rapid talking. That's probably something I may be doing a little bit at the moment, but some people talk really fast. And you find that they speak really, really quickly, and they get to the end of their sentence, and then they take a big breath, ready to get going again, and then they start talking again really quickly. The other things that we need to look at are the musculoskeletal assessments, so looking at the neck, head, shoulders, breathing pattern, full body assessments, and posture. You can imagine that for people who are very breathless quite frequently or chronically, they will often have that upper chest breathing pattern. And so when you are very overactive in this part of your body, your posture is sometimes a giveaway, and you are very, very tight through that part of your anatomy. So how do we treat breathing dysfunction? The most important thing for everyone here to know tonight is that it's really the first thing we have to do is educate people. And it's really education, education, education. The most important thing that everyone needs to understand is that they are really common problems. And like Barton said, just because there's no underlying, not necessarily, but maybe not an underlying lung condition or a heart condition, doesn't mean that it is not a condition that we need to treat. But it takes time. It really does take time. Changes in breathing patterns related to breathlessness generally do not happen overnight. It is a subset of a period of time that causes these problems. So it's really important to understand that it takes time to reverse them and takes work. So as respiratory physios, we work with the Radcliffe breathing method, and it is a breathing retraining method, which Ali will teach you a little bit about in a moment. So we do a lot of breathing retraining, And we usually start this retraining in supine. Supine, again, actually means lying flat, not dead flat, usually with a small incline. The reason we start very, very simply, though, is to make sure that you are at your most relaxed position. So you need to appreciate that if you are trying to implement a breathing, a new breathing pattern in a time of stress, then you need to teach your body to be able to do it with no stress and in the most simple position. We then progress that usually to sitting and standing, and then with exercise. Inspiratory muscle retraining is something else that we work on. So we do a lot of strength training with the diaphragm. We do a lot of work around relaxation, nasal treatments, which I've already spoken about, and then home programs. So this is really not something you can come in and learn how to do straight away and then go away and it's all fixed. It's one of those things you have to go home and you have to practice regularly each day. So usually 2, 3, 4 times a day, not for long, but for a little while. And sometimes we combine that with airway clearance. So Barton spoke about the combination of maybe asthma or COPD or emphysema or bronchiectasis or bronchitis, conditions where you have sputum clearance problems. And for that, we may combine it with another treatment to help you manage your sputum at that time. So that is, in a nutshell, how it works. But what I'll do now is I'll hand you over to Ali, who's going to take us through a very simple breathing pattern to try and get familiar, I guess, with what sort of patterns we have. So I'll stop sharing there.
Hopefully everybody's enjoyed this, and it seems like that there's been good interest from the chat and things, which is excellent. There's one thing though we would really love for you to be able to do for us, and that is to tell your GP. So what we're keen to build our practice, and essentially we are striving to be the best respiratory practice possible, and to do that, to be able to fulfill our mission, which is to help and inspire as many people as possible to improve their overall health and quality of life through specialist attention to their breathing and sleep health. And so it's really helpful for us if you get a chance to tell your GP or your doctor about us and about what we're doing, and if that can lead to them thinking that we might be able to help their patients, and that will help us fulfill our mission, and we'll be really, really grateful for that. So Ali, are you ready to go?
Yes, I am.
You are ready to share your slides, and I am ready for your breathing exercises, and I've actually been quite looking forward to this myself. I'm going to get into it. I'm going to do it with you. I'll leave my camera on so people can watch. If people do feel more comfortable turning their camera off, you can turn your camera off. But it'd be best if everybody gets into it and gives it a go, as Ali's going to take us through some of her breathing exercises. So thanks, Ali.
You're welcome. I hope you can all see my screen. Yes, so I'm one of the respiratory physiotherapists at the Bentley Specialist Centre, and I may have met some of you and might be yet to meet some of you. But I'm going to jump straight into it, and it's time for action. And, hopefully I'm confident that you will learn something about your breathing today as well. So as Leah mentioned before, education is the key to empowering breathing retraining, and a good place to start is to gain an understanding of the way you breathe yourself. So I'm going to invite you to participate in a short activity with me, and like Barton said, you are welcome to turn your video off to give you some privacy, and I will actually encourage you, as you sit in front of your screens, to, if you can hear me all right, to close your eyes as I ask you to reflect on some of the following questions that help you to observe and learn about your breathing. So here we go. So as you sit back, in your chairs or wherever you're sitting, have your eyes closed. Try and relax. And as we're receiving all this information, just pause and begin to tune in to watch your breathing in and your breathing out. Take note of where you are breathing from. Is it your nose or your mouth? as you observe your breath in and out, which one is longer, your breath in or out? Can you identify a brief pause at the end of your breath out before the next breath kicks in? As you do a mental scan from your throat down to your pelvis, where do you feel lies the focus of your breathing? Think about the movement of your chest and your belly. Which one moves first? Which one moves more? All right, I'll get you to open your eyes and join back in the video. So I'll talk through some of the desired answers, and I hope you found that exercise, somewhat revealing about your own breathing. And as I go through, the desired answers to these questions, if yours was somewhat different to what I am going to say, that it might be indicative of a breathing pattern dysfunction. So we should be breathing in through our noses, as Leah mentioned. Nose breathing helps to engage the diaphragm. When you observe your breath in and out, your breath out should always be longer. This is something quite common that I see in clinic, where someone's breath in will be just as long as their breath out, meaning to say that they're not quite fully emptying, properly emptying their lungs before they're stacking on the next breath. And so that breath of fresh air eventually gets smaller and smaller. And you can see why someone then starts to feel quite constricted or limited or breathless with their breathing. Likewise, did you identify a short pause at the end of one breath before the next breath started? So that pause indicates the natural and true end of one breath before you're breathing in too quickly again, which can be quite characteristic of some subtle hyperventilation that we see in some clients as well. When you scan from your throat to your pelvis, we like you to identify the focus of your breathing to be in your belly, which tells us that your diaphragm is the main driver and the key muscle in doing normal, healthy breathing pattern. And not only would the belly move more than the chest, it should be the first one to kick off to initiate the breath. Okay, so I hope you found that helpful. Now, we're going to go through quite a common technique that we can spend quite a lot of time on this in clinic, because it's a very effective technique in doing diaphragmatic breathing. So I think people have probably, could have learned other techniques to do diaphragmatic breathing in the past. And we're going to run through a shortcut in this session. Okay, so if you'd like, again, I encourage you to switch off your videos if you like, to give you some privacy or allow you to concentrate. Sit back in your chairs and close your eyes as I talk you through some instructions. Now, you must be able to relax, and you can't be slouched or crouched over, because we want the chest and the bellies to be able to expand freely. And when I pause in between the instructions, don't fret, we're still here, but I just want you to relax and allow time for the body to respond and make the changes to your breathing. Okay, here we go. So as you sit back, relax, and close your eyes, I want you to start by loosening your shoulders. Give them a shrug up to your ears and slowly unravel. I want you to imagine tension running down your arms and out through your fingertips. Make a double chin by tucking your chin into the back of your throat and relax. Loosen your lower jaw, wiggle it from side to side. Stretch your mouth out wide and bring your lips softly together. Your lips should be touching but not biting. And rest the tip of your tongue on the back of your top teeth. Tune in to that flow of air in and out through your nostrils. With your eyes closed, raise your eyebrows. Feel a stretch across your face and relax. Bring your focus back to that flow of air in and out through your nostrils. We're going to stay in this moment. Your breathing is low. Your breathing is slow. Your breathing is long. Watching your breathing in and out. Which one is longer? Can you note that brief pause at the end of one breath before the next one kicks in? Tune in to the gentle rise and fall of your belly. You may open your eyes and rejoin with your video. I hope everyone, maybe you might have noticed a change in the way that you were breathing following that exercise. And I'm not going to spend too much time dwelling on this slide except to say that it's not a one size fits all when it comes to breathing retraining, but there's a range of treatment techniques that we can use. But in summary, breathing training needs to acknowledge the three domains that Leah spoke about: the biochemical, physiological, and psychological influences on breathing. And remembering that the diaphragm is quite a special muscle. It's got voluntary and involuntary control. So, breathing retraining, when we work with the diaphragm, it's going to be different than training up the biceps muscle in the gym. But what's required from you is that diligence to stick to it, and know that breathing retraining becomes a lifelong skill with benefits for the biochemistry, physiological, and psychological well-being of your body. And with that, I will conclude by saying that better breathing will be better living. Thanks, Barton.
Anyway, thank you, everyone. Thank you for coming out tonight. It's been excellent. I have just put the feedback form link back into the chat. If people are able to click on that, it'll open it up and you can fill that in. It'll only take about 1 minute. That'll be excellent for us. And please do remember to tell your friends, your family, and especially your GP about what we've done tonight. And if it's been useful, that'll be fantastic for us and greatly appreciated. All righty. On that note,
guys. Nice to see
we
you.
will